Professor Mohammed Mashyakhy is with us today. Professor Mohammed Mashyakhy have a lot of experience in the world of dentistry and a lot of education. He did his first bachelor's degree of dentistry in King Saudi University, and also he did his master's degree in dentistry in the University of London. Also, he did his specialty of clinical endodontics in the University of South Carolina and the New York University. Also, he is a board member of the American Board of Endodontics. He is at a diplomatic level, and also he did his PhD in the University of Di Roma. So, Professor, I want to welcome you and everyone here in this participant. Uh, Please join us for this amazing session. It will be in a two session. Today will be the first session, and next week we will have the second session. So, Professor Mohammed, the place is yours. Let's continue.
Yeah. Hello, everybody. How are you? Hope you are doing good. Everybody hearing my voice clearly? Give me just a thumbs up that my voice is clear so I can continue. Perfect. So thank you very much, everybody. Thank you, Mr. Moderator. Appreciate your nice introduction. And thank you, everybody, for coming. And thank you for having me. I have been to this for many times in Ethiopia, and I wish to come soon, inshallah. So without any further ado, today I will start my presentation. So the name, as you can see, Understanding and Managing Challenging Endodontic Cases for Dentists. So this lecture is basically for dentists who are practicing some endodontics. I'm not talking about the full field of endodontics, which is a bit difficult, but at least they are practicing in a daily practice that you have doing endodontic treatment. So here we're going to have some thoughts, some understanding, some clinical tip and tricks. Those people who don't have that experience also will definitely benefit from the lecture by having like knowledge and some theories and some like evidence-based literature here. So today, first thing I will start about, which is very important to me, why we do root canal treatment. So basically there is one main goal in all endodontic, in all like dental specialties. We are the almost only one who are specialized in saving teeth. So we are the last resort. You know, everybody at the end, they send it to endodontics. If you cannot save it, so the tooth will go for extraction. I'm talking about not periodontally involved teeth. That's another issue. But I'm talking about like caries teeth, which is our main enemy, which is the caries. And also apical periodontitis, apical lesion, big radiolucency. In the past, a lot of people, whenever you see like dentists, whenever you see a big radiolucency like the one here, they tend to extract the tooth immediately. However, these teeth can be saved easily by doing root canal treatment. So what are we specialized in? Saving natural dentitions. What are we dealing with? You know, research has been proving since the Kakihashi project in '65 that the microorganism or the bacteria are the main enemy of us. So whoever those people doing root canal treatment without addressing, disinfecting the root canal system, you know, actually you're not doing a root canal treatment. I'm sorry to say that. So here the concept, this topic or this slide, whenever I do any lecture everywhere in the world, I do this slide because this is like, it's the basics. If you don't do this basics, there is no need to do any other root canal treatment or any difficult cases because you violate the basics. The main thing, we have to do isolation. We have to do work our job in aseptic technique by using rubber dam. Simply brace the rubber dam like that, and hopefully you'll get away from saliva, from blood, from the gingiva, from the tongue, from everything. The second thing, we have to do the cleaning and shaving thoroughly using sodium hypochlorite, which is very important to kill the bacteria and dissolve the organic tissues. Simple one, easy from the market, that will do the job for you. And also shaving the root canal system for obturation. We have to obturate the case eventually. And we have to do a very good obturation so we can have a tight seal apically and coronally. Then eventually we have to end up by a filling. A good filling, a coronal to prevent the coronal leakage is very important. So this is like the 5 main concepts and rules in endodontics. You can do it in so many ways, but eventually we have to do it all. Otherwise, you are just ignore. If you ignore the concept, you will do all the job. You will be really tired in the clinic. dealing with many canals, saliva, tongue, everything, then eventually you will fail because you're not following the concept. So let's just all agree on this so we can go forward. So there is I'm sorry I put this in Arabic, but I will explain it in English right now. There is a big Chinese guy, more than 500, 500 ago, before like Jesus, whose name is Confucius. That guy, what did he say? He say, I hear, then I forget. I see, then I remember. I do, then I understand. This is the most basic way to learn and to teach dentistry and any other specialty as well, but especially in our field. You have to read very well. You have to see, listen to your professor. You have to read and study so you can remember. Then you have to do it clinically so you can understand perfectly. Also, we all like well aware about the monkey see, monkey do. That's what we are all doing in our specialty. We see your faculty or your supervisor doing this job, then you just copy him. But eventually, from my experience teaching undergrad, postgrad, and working in my private, I realize, especially with the young generation, we have a big problem because there are different specialties. And all the specialty in dentistry has its own way. For example, if you're doing an oral surgery and you tell the student, please put the forceps like that and move the tooth like this, the student can see you and he can follow. But in the root canal treatment, unfortunately, you tell the student, okay, curve the file, put it, find the mesiobuccal canal, then put another file and put it in the NB2, then bypass the curve. And the student, without a loop, he just go and he got that big smile in his face and he doesn't know what you are saying exactly. And he just put the file in the canal. He doesn't know what the file goes. Then he go home, then I hate endo. I'm not gonna do endo at all in my life. That's because the way we teach endo and the difficulty of the endodontic treatment and endodontic education as well. So I develop, or like I'm working like in a so simple theory. When you're teaching root canal treatment, and now for you as a student or GPs or whoever like to learn, if you are with a mentor or you're with a professor, first you have to listen if what he's saying to you. Then you have to do what he is saying to you. Then you can understand later. For example, you are in the session with the student. I just right now came from a session. And you tell the student, okay, put the file on 20 millimeter, take X-ray. And the student start arguing you. Why we do that? Why don't we use the apex locator? Why 20? Why not 18? This is not the time. In the clinic, just listen, do what I'm saying to you. After you dismiss the patient, then we can sit with me, discuss with me, then we can understand. Because there is this skill, whoever like working in endodontics for a long time, you know, it's not easy to learn endo. It takes me many years to understand some of the concepts. So, but you have to master the skills. Then the understanding will follow. Unless you are super smart or you are like really taking it seriously. So we read before you come to school once and twice. This is another issue, and that's what we'd like to do. But in general, just listen to your instructor, listen to your mentor, listen to whoever like he's teaching you, and do exactly how he's saying to you. Then ask him, read about it, go to YouTube, search it, then you will understand fully. So let's talk now about the difficulties in endodontics and the scope of this lecture. First, anatomy. Everybody knows like anatomy, it's very difficult. Whoever work endo knows the anatomy is not an easy, and everybody has his different anatomy than the others. So be aware from anatomy always by taking x-rays, by taking CBCTs, by even like taking natural teeth extracted and work it out, cut it and see it under the little loop of the microscope. And actually the difficulty is not only the anatomy and the curvature. Some patients, they have limited mouth opening. Some patients are not cooperative. Some patients are afraid. They don't let you do your job. Some canals are curves. Some canals calcified. Some teeth have open apex. Some teeth came with like a big lesion. So there is some cases also comes with a separated file inside or broken file. So difficulties is really many difficulties in endodontics. But today I will focus that the difficulties that at your level, you can learn it easily by having a mentor or having a lecture or watching some videos and having the proper instrument and materials. So let's go forward. So what do we need to have? First, we have to establish a good diagnosis. If you don't do a good diagnosis, so you're not eligible to treat a case. If you cannot diagnose, send it to somebody else. Please don't do any treatment without a proper diagnosis. The second thing, we have to have a sound knowledge about anatomy. You cannot just go inside the tooth and blindly without at least having an image in your mind. Because if you read anatomy, if you see like pictures, if you open the textbook, you will see that central incisor, for example, upper central incisor, most of the time are one canal. So rarely you're going to see another canal. But if you go to the lower central incisor, there is a big percentage that you have the two canals. So whenever you open that tooth, you are aware you might have another canal. So by have a sound knowledge of anatomy, so you are prepared. Whenever you have an obstacle, you know there is something else going on. Also, you have to have at least loop with the light. At least, if you, I know having a microscope is not an easy job, but having a loop is a must. So if you are doing root canal treatment every day, especially premolars and molars, 2 to 3 cases, you have to have a loop. If you are doing root canal treatment as like an emergency once per week, then it doesn't worth an investment. So this is how the magnification can help you in the clinic. This patient came to me like this with a pulp chamber, you cannot see anything, and with the loop, and then after that I use the microscope, and you can see how the pulp chamber looks like. So we cannot ignore this fact. A tooth like that, you cannot do it without having a magnification. CBCT, whoever have a CBCT, you will see the big benefit that we have from the CBCT. I can know from the beginning if there is another canal, missed canal, how big is the lesion, is it close to the sinus or not. So if you are a specialist in endo and not having a CBCT, this is really, you are missing a lot. So you have to have some people around you with a CBCT machine. So some cases has to go for a CBCTs. And this one of the cases that I worked last week. I was working this tooth, came to me with the patient came to me, previously initiated. The previous dentist opened the mesial and distal. Then he was digging very badly in the mesial side. He didn't find the mesiolingual canal. So when I start the patient with using my loop, I thought things will be fine. Then I see how much damage is being done, and I didn't see any other canal. So what I did, I just take the rubber dam out, take the patient and take a CBCT, and I realized that the mesial canal is only one canal. So there is no point of wasting time and looking for the other canal. So I just continue and finish the case immediately in the same visit. So this is the benefit of having a CBCT machine at your office. What else we have? You have to have a good armamentarium. Like this is handpiece, is not a regular handpiece. This handpiece is like a mini handpiece. For those patients who have very limited mouth opening, this handpiece can be of help. So you can go to the tooth number 6 or 7 easily. We have to have different kind of burrs, and you have to have like slow speed burrs with different size, ultrasonic tips, and some C files, especially for calcified canal. So without having all of these around you, it's going to be really difficult to manage difficult cases. Also, whenever you have any canal, I would recommend this for any canal, not even the calcified or the difficult or the curved canal. Please don't start with a big file. Don't use the 15. Always start with 10, 8, 6 if needed. Because number 15 is very aggressive file, and most of the students, most of an expert dentist, they always do a lich because of the 15. So please always use a smaller file. What kind of different files present in the system? Now I believe so many files are present in the system, especially those one they call them heat treated. What do you mean by heat treated? The original files, endodontic file, which is the NITI files, it's very flexible, but it's prone to fractures. It doesn't take like long working with the teeth. But this heat treatment, they put the files under some heat until it gets some extra properties. It becomes more flexible, it becomes more resistant to fatigue, and it also when you bend it, it's stopped as it is. With this one will help you if there is another canal, so you can negotiate that canal. You can go take the curve and put the file in the canals. So it's very helpful. And we need to know very important things about rotary files, the tabers. If you have a small canal, use small taber. If you have a big canal, use big tabers. This is basics, but just for the sake of like refreshment. So look at these files. You see, all of them are curved, right? Because they have a heat treatment. So when you bend the file, it's stopped like this. When you put it in the root canal treatment and you start working, the file goes to its original shape. Look at this video. They put a hot water on these files, and all the files it goes back to the original shape. They call this like memory of the file. The file used to be straight, but with some treatment, it becomes like more flexible and it takes the curve. So that's what happened in the root canal system. After you curve it, put it in the root canal system, what happened is because the heat, the file becomes straight. So all of these armamentarium, all of this new generated file, all of this heat treatment is very important to manage difficult cases. Even myself at this experience level, when I'm helping sometimes some student with difficult cases, I cannot work it very well because they don't have enough instrument. I have to tell them, okay, bring the patient next week or bring some instruments so we can do the job easily. So far so good. I will start with one of the cases that comes always to the clinic, which is calcified teeth. So calcification, especially in the anterior teeth, happens if you have a trauma, either an accident or like fighting or whatever. So what happened, the acceleration of the deposition of dentine within the root canal system because the pulpal response. So the pulp becomes very calcified, and even you can see the discoloration of the crown and the tooth. You can see that it's very discolored. So these teeth, it doesn't need to be necrotic. Sometimes need to be necrotic, but because the changing of the color, it makes you like when I do the treatment, so you can the tooth make it very lighter. And sometimes it becomes necrotic, so we have to do the root canal treatment. So this is one of the difficulties that you're gonna have. You see, calcification, it doesn't always come from the trauma, especially in the posterior teeth. When you have a big filling, when you have a caries, when you have like extensive work on that teeth, so the pulp chamber tend to be smaller and smaller, and this is like as a defense mechanism. So we can see a lot of calcification in anterior teeth because of the trauma, and posterior teeth because of the caries and restorative work. Other thing, and some of the difficulties you're gonna have in the clinic, which is the curved canals. Curved canal, it can be like simple curve, acute curve, curve through all the canal, dilaceration. Dilaceration means at the end of the root, there is a very steep curve. And there is so many definitions of that. We're not gonna go around it, but whenever you have a curved canal, so there is always like possibility of having a ledge, blockage, perforation, and apical transportation. And here we can see some of the problem we can have if we have a curved canal. So you can have a lid, zipping, or like strip perforation or apical transportation. These all comes with little experienced dentist, and also with some instrument. If you don't have the proper instrument, proper management, you will end up by having some of these problems. Definitely, I believe everybody from our lifetime doing root canal treatment, we have some of these. But this is one of the common mistaken problem everybody almost had before. If you have a curved canal and you're working with hand file, stainless steel hand file, you will end up by this shape, which is very you don't want to see it in the clinic. Type of curves, there is so many curves. One of the beautiful curves that I like, they call it the banana curves. You see how the banana curve, it's long and it's a big curve, but it's very smooth. So this smooth curve, if you manage it in a proper way, it becomes really easy curves. The problem is with the different kind of curves. The one would have like a double curve, steep curve, or like a curve in a different dimension, let's say mesiodistal and buccolingual. Some teeth comes like that. So this one is really difficult. Look at this anatomy here. Look at the molar. See the mesial and mesiobuccal and distobuccal root, how it's like curved at the end. Look at this premolar, how that the big curve. So the curve here, there is something important to know about curves. They call it the radius, the angle here. If we have that picture on the left, and you can see the curve is very long. It's like we call it the banana curve. This is easy to manage. But if you have a curve like this, the one in picture B, this is very prone to fraction. And here, this angle, it can be the same angle, but the curve is different. Okay, I mean the same angle if you measure it, but where the curves happen, how the steep of that curve and the angle of that curve, so there is some differences. So this will add difficulties to the case. So the case on the left is much easier than the case on the right. Look at this case. Some cases have a double curve, but this curve, it's like in a mesiodistal direction. The problem is when we have a curve on mesiobuccal and buccolingual direction at the same time. This is very simple anatomy of the upper lateral incisor. Look at the anatomy, how it looks like. Can you see there is like mesiodistal curve and there is buccolingual curve as well. And this is only the upper lateral incisor. It's not a molar at all. So we expect more difficult cases, and we always think about the hidden curves. Whatever you see in the preapical X-ray is not the real curves. Okay, put this in your mind. So let's go forward. So the management of curved and calcified canals. I will go for this topic, then I will go for another topic. Always establish a good diagnosis. Always take X-ray before you start. Good knowledge of the anatomy. When you see something wrong in the X-ray, pre-apical X-ray, go and take a CBCT before you start. Practical access cavity is a must. Try to get original shape of the pulp chamber. I will explain all of this in picture. I'm just showing the protocol, then we go forward. Apex locator is a must. Straight line axis, coronal flare-up is very important to manage difficult cases, especially the curved one. Pre-curve small hand files. Always whenever you put a file inside the canal, don't put it straight. Try to do a small pre-curve of the file so you can follow the exit of that canals. Glide path files is very important, and I'll show you how to use it in the presentation. We have to have, or it's better to have, high-speed rotary machine. Most of you guys are using the speed of like 300, 400. Sometimes in some cases, it's better to go for a little higher speed, okay? Some cases. We have to have a flexible rotary file system, and we have to have O4 taper. What does that mean, O4 taper? I explained before, there is like auto taper, which is like the ISO system, the same hand file we have. There is O4 taper, and there is 606 taper. 06 taper is really big. It's not recommended for curved or calcified canals, okay? So when I'm saying that by going to the original shape, so whenever you have a calcification in any tooth, try to remember the original shape of the canal, because that canal, originally it has to be in this shape. Then eventually it becomes more calcified. So by getting the original shape, it's gonna be easy for you to follow and find the canals. The steps is always measure from the tip of the root of the cusp to the pulp chamber and try to go with the burr. So we go to this side. After you reach that level, you never ever go further, because if you go further, you will just only do damage. All the movement is lateral movement. And this is true if you have the calcification. If the pulp chamber is calcified, just measure from the top of the cusp to the area of the pulp chamber and do your measurement and do the drilling with the burr. After that, we have to do the coronal flare. This coronal flare will help the file and the rotary system to go straight to the canals. This one is very important to have, especially in calcified canal. You just dig to the pulp chamber, to the orifice. Try to find the orifice with this one by poking. This one, just put it in the pulp chamber and squeeze it harder to the place where you expect the canal to find. So if you are talking about the lower molar, try to find the distal first, because it's the bigger one. If you find the distal, then it's easy to go and find the mesial. In the molar teeth, try to find the palatal, because it's the bigger one. So when this one, press it hard and you go to the palatal, then it's easy to follow and find the other canal. Here, what I mean by straight line access. After you get access to the pulp chamber, and the first 3 millimeters from the orifice of the tooth, orifice of the canal, to the middle of the root. This is very critical area. So always try to make it straight. So whenever there is like two curves, you have to get rid of the first one. And if there is no curve at all in the canal and you remove it from the beginning, your life will be much easier. And if there is a double curve like this here, and you get rid of the coronal one, your life becomes much easier down there. So put this in your mind. Coronal flare is very, very important. For example, look at this case. Very simple axis. However, we have very straight line access to the root canal system, as you can see here. This other case has been done through the crown, and you can see how can I get the straight line access, and we finish the case. So now, after you find the canals and you do the straight line access, you put the hand file, take an X-ray, make sure that the length is fine. So you have to establish a smooth glide path file. You can do that by having small hand files or rotary files. So it's very important to have a glide path, because you will never have a ledge, okay? No transportation. It's very important in curved canal, and it will guide the rotary files. For example, if you go with a curved canal and you go forward all the way down with the small hand file or with the small rotary files, then the canal becomes very smooth and you will never do ledge, because you are smooth all the way down. The problem is why people are having ledge, because they shuffle a big hand file, 20 or 25, and try to getting around the curve before doing even a coronal flare. And that's why you have a ledge in there. So having a smaller file, having a glide path files, it will help you a lot. And it's always achieved by small file, as we said, and we can have some lubricant, RC prep, which is called EDPA gel, okay? So here some files are rotary files to do the glide path file. It's very small files. The tip is 13 and taper is 02. It's like the hand file, the regular hand file, and it's very flexible. And you can always use other companies files like the one down, which is like progressive taper. Those one have a fixed taper. They all look the same, right? You see the blue one, the white, and the yellow. They all have the same taper, but they have a different tips. So this one, it can go through the canals very easily and nicely. I'll show you some videos. Here in this video, we can see how they do with the hand file. Look at the hand movement of the operator. See how the movement, there is no continuous clockwise. It's always like watch winding movement. It's like right, left, right, left, right, left, right, left, until he reach the final working length. Okay? So it's as easy as that if you follow the correct motion. Correct motion is very important. Those people who put the file and they screw and screw and screw, they always end up by having a ledge. Another case here using a rotary file. Look at this. After inserting a small file all the way down, and there is a curve or a double curve, see the hand movement. Is this the secret? If you don't have a rotary file, you have to do this with 8, 10, 15, then you continue. Look at it here. He passed the apical part. Then he can take the rotary file. See how it looks like. See how it's very, very flexible, very beautiful and flexible. So this one, it can go through the canal. It's very easy. Just watch the video and enjoy. See? And this one, for the sake of video, I think there is no much lubrication. There is no solution. But in the canal, normally you have to have always, canal should be full of sodium hypochlorite. Okay? So it's very easy. After you reach to the 15 or 20, then you owe the canal. Every file later, rotary file system, it can follow and you can do the root canal easily. I don't know, everybody seeing the video clearly? See the apical part? He already passed the working length. Normally the working length should be inside, but this is just to be safe. So getting out a little bit, 1 millimeter out of the root canal system, you will never do a ledge inside because you are already outside, okay? So I will give you some tricks. Go beyond the curve with a small rotary file, as I said, and as I show you in the video. If you go a little bit outside, you will never do a ledge because you are already outside, and you will never ledge if you are out, okay? It's very clear. Hopefully you understand this part. Otherwise, in the question and answer later, I can explain more. So let's now start with the clinical tip and clinical cases. So this case, tooth number 7, okay, which is 17 here. I mean, at your system, you call it number 2, okay? Upper right, 7. So this tooth, it has 2 problems. First problem, distal caries. Second problem, small mouth opening. So it was very difficult to go with your with a regular handpiece to open access cavity and to do the root canal treatment. So if you want to get the mesiobuccal canal is the one, it's more difficult. So if you want to go to the canal by this way, it's going to be really difficult and very challenging. And how can you get the handpiece all the way down to get the file there? You will have a separated file. What we want to have a line like this, straight line access to the root canal system. The distal is easy, as you can see. We have a straight line access to it. So if you put the rotary system with the machine like this, immediately, it will go and it will curve, take the first round, and it will break because you don't have a straight line access. But if you come from this side, it will work. But if you have very flexible file, it will go around the curve and it will be fine. If your file is not flexible enough or you don't have that enough experience, it will go around and it will break. So what should we do? The distal will be easy because we call this trajectory. What I mean by trajectory? That every canal has its own path. Look at the distal like this, the mesial like this. This is very important to do it in the root canal treatment. So what we do here, we take a handpiece, round bear or taper diamond bear or Endo Z, and we try to remove this dentin here. After removing this dentin, then we can have a straight line access to the root canal system. And the canal can be done very easily like this. So this is the first case, how to manage, especially tooth number 7, the back in the mouth, by having a straight line access to the canal and by having a good trajectory. What I mean by trajectory is to insert the file with the path of the canal, like this one here, like this one here, okay? I will show you now another canal. It's almost the same challenge. You see the mesial canal, how it looks like, but this is number 6, much easier. One of the inexperienced dentists, he worked with me in the clinic, he separated the file. Can you see the file in the mesiobuccal canals? It's very clear here. Because he didn't follow the instruction of having a straight line axis, and he put the rotary file, he thinks the rotary file will do the job. No, and it breaks. So what I do, I just follow the rules. I did as always I'm teaching and as always I'm doing. I first remove something of the dentin so I can have a straight line to the canal. Then I starting by, here there is MB1, MB2. I started with the other canals that it doesn't have the separated file. And I use this beautiful file. This is from Dent. And see how it looks like. One of the canal has file number 10 and one of the canal has the rotary file. You see the difference of them? I see how the double curve inside because I already have a straight line access to the canals. Then we ended up by having this beautiful root canal treatment. Okay, so all of that because I'm not super smart or super experienced, no, because I just follow the rules. Just have a straight line axis and use the right rotary file. Everybody can do it. Okay, there is no like magic or no nothing. Just do the correct things, follow the steps. And see, this is from a different angle. Here, this is a difficult case. You see the root canal anatomy here, there is something wrong, correct? Normally, upper molars, it has a 3 separate root, correct? But here, from the periapical X-ray, it looks weird. The pulp chamber, well, this is one of my friends called me, Doc, I tried to find the canals, but I couldn't. And he sent me the picture, this apical radiograph, and he sent me the photograph from the pulp chamber. So what I did in this case, first, because I understand anatomy, and this is one of the publication I did about this kind of root, there is some molars are merged together, 6 and the 7. And if the root canal, if the root system are merged, like the roots, mesiobuccal, distobuccal, and palatal merged together, so we expect to have merged anatomy inside. And this is what's happening inside. So it looks like this. This is how it looks like, some of the buccal, some of the maxillary teeth. It's very weird. So I take a CBCT, then I realize that there is joint root, and there is 3 main canal, and there is 1 simple canal might be found in there, and I see how deep is the calcification. Then first, as we said, we try to get the canal to the original shape. So here, using the small round burr with the slow speed, clean around, using ultrasonic, trying to get the original shape. Then we find, you see here the palatal, and that white thing is the sodium hypochlorite. Then eventually I use, as I said, this instrument, ultrasonic. I use a small file for calcified canals. I use the Muntz burr. This is like a very long round burrs. And it's very important, and be aware always to have apex locator with you when you are working on calcified canal or curved canal. Why? Because if you find an opening and you put the file, so you have to attach the apex locator and put your other hand on your heart. If you see the red sign in the apex locator, what does that mean? Who can answer me here? If you find the canal in the calcified root and you put a file and you see a red sign in the apex locator, what does that mean? Can somebody answer me in the box? Perfect. That is perforation. Thank you, Mr. Mohammed. Exactly. So always, if you have a difficult case, calcified or curved, have your apex locator always attached. So when you put the file in the opening that you have, so start with a small file. Don't go for bigger file. Before, even small file can go 1 to 3 millimeter to any catch. Attach the apex locator and see. If you don't have a full reading, perfect. You are in the right path. So you have to go 1 by 1 or go to take an X-ray and come back. Perfect, guys. So apex locator is very important. So, and this is how we ended up the case. By the use of the microscope, ultrasonic, small file for curved canal, and some flexible file. You see the mesiobuccal root, how it looks like? You see the palatal, there is 2 palatal next to each other because, as I said, the anatomy are joined. And this case are done in 1 visit, by the way. Most of my cases done in 1 visit because I have the instrument, I have the material, I have the microscope, I have the loop, I have the CBCT. So everything will be fine, okay? This is another case is done with one of my previous students. Now he's a pioneer. See how difficult is this case? Somebody had tried before to open and he couldn't find. You see the calcified canal. Then this is how pulp chamber looks like. So what he did, as I said before, he put the file, he find the catch, he attached the apex locator, then there's no red sign, so he take an X-ray. When you take an X-ray, you confirm you are in the right path, so you can go forward. He got the distal all the way down, then how it looks like. So for example, this case, let's just talk about it. If you find the canal like this, then you can go forward. First step, what we do, especially in the mesial, he already go all the way down to the middle of the root. So this part, the one is already clean. Use the orifice opener, make it bigger, make it flare, inject sodium hypochlorite, inject some ADT gel, use a small file again or rotary small file. Try to go all the way down, touch apex locator or take X-ray. If it goes all the way down with you, like here. So when you go all the way down, this, I believe this file number 6 or 8. So all you need to do is like follow with the bigger file. So this is 6, go with the 8, go with the 10, then take the rotary file, small glide path file, it will go easily. Then follow the sequence, 15, 20, 25, 30. Use the small taper that will fit this small canal and see the result. Very beautiful. So you cannot believe this case started from here and ended up by here because he just followed the system and he had the instrument, okay? This is another case I did in the clinic. You see how big is that curve at the apical part? And but alhamdulillah, by having the instrument, the correct one, that flexible rotary file, heat treated, then this can be done easily. This is another tooth. It looks like easy, but it's tooth number 7. There is a double curve inside in a different dimension, and accessibility is very difficult in the mesial. You see how deep you can go in the mesial, then you find the canals. But you know, with the help of the super elastic files and with the help of that, I have a loop with the light so I can see what is the canal exactly. Then things goes very easily. This is how it looks like from a different angle. You see the curve here. There is always a curve in the canal. Even you see it or you don't see it, there is always a curve. So every tooth you treated as having a curve, okay? This case came to me from outside. You see, the previous dentist tried his best to open a canal, he couldn't. So what I did, I found the distal, the mesial, I just went only one canal. I tried and I tried and I tried, then I couldn't. So I eventually finished the case and the patient came after 3 years and everything is fine because the other canal is completely either missing or completely calcified. And thank God there was no infection in that canal. So don't be upset if you don't find the calcified canal, okay? So this is another case. So this case is very good. You see the calcification in the pulp chamber. When you get to the pulp chamber, just go inside, use the ultrasonic. As you see, this kind of ultrasonic tips, it will break all that small calcification inside. Then we just follow the step. Stick the file, at least to the middle of the root. Try to do a coronal flare with the rotary files. Then you follow the small files to get the working length. Then you take it one by one, step by small rotary files. And this is how does that case end it up. In the anterior teeth, there is some sophisticated people who have the money and who have the machines. They did guided endodontics. So they take a CBCT and they took a digital scan. They take it to the lab and they got like a stent. So they put the stent on the patient mouth and they start drilling one by one until they get to the root canal system so they can perform the root canal treatment with a small access opening without wasting a lot of tooth structure. And here also another case, you see, he do the stent, put the stent in the tooth, start by smaller burr, get with the file there, and he finished the case. Here's some cases I have treated. This one, central incisor with 2 roots, because I'm aware of anatomy. I know there is so many things might happen. With the help of the magnification and with the small files that helped me, so I could find the other canal and treat it. And this is like a follow-up case. Here, one of my student and one of my employee now, he worked with us. He is a general dentist, but super dentist. This is a difficult case, very calcified. Why I bring these cases for GPs? Because if you, as a GP, work with some good endodontist, he can show, or any specialty, he can show you good cases, and he will show you the right instrument, the right path, so you can just follow. You see the calcification, how it looks like? He opened very small access cavity, and he find the tooth. So he got into the tooth with the small root canal file. Then he just follow with the system he has. So whenever you get to all the working length with file number 10, you own the case. You can go with rotary file from the smaller until to the bigger master apical file. And this is another case he did. See this calcification? He managed to open here and finish the case. All this done by like a GP. So everybody from you guys, from today forward, if you have a case like this, you cannot manage it, take it to an endodontist or somebody who is expert, go and attend with him, sit with him, let him show you how to do it. Next time you can do it alone, believe me. This is another case came to my clinic, canine in both sides, lower canine all like calcified and one with a separated file. So what I manage here, I open a little bit, then I go take X-ray and I find the path that I was digging in the wrong place. So I can now find the canal and finish it up. The other one, the previous dentist, he was like gouging in the distal direction. However, the canal was more mesial. So I catch the canal. How did I catch the canal? I get the tooth, the canal to the original anatomy, access cavity of the canine. I start with small file. I catch the canal. I attach the apex locator. I know I'm in the canal. I do a little coronal flaring with the rotary files. Then I put another small file again. So I reach the working length, 6, 8, 10, or if you have a small rotary files, use them. Then once file number 10 go all the way down, you got the case, okay? There is no reason, whatever, if you have file number 10 or 15 go all the way down, not to finish the root canal treatment, because there is no other excuse, okay? Here are some cases that you will have in the clinic where you have like split canals. Split canals is really difficult at your level, but I want to show it to you here to know your limitation and also to know that the benefit of having magnification. This case referred to me from the student. There is something wrong in the premolar, right? After we open the access cavity, you find the buccal and the palatal canal. But with the help of magnification and ultrasonic, you see there is another opening in there. And by putting the file, you can see there is two buccal canals and one palatal. So this premolar trying to be a molar, okay? And by having the obturation comes like this, and because we have the magnification, you see, with the magnification, I can see where is the split, and I can clean and shape, and I can put the catapertia and carry it one by one and fill the rest with the injectable catapertia. These kind of cases, you cannot do it if you don't have magnification, loop with a good light or a microscope. Very difficult to do it without have that. If you don't have any of this instrument or armamentarium, send it to somebody, he does. The other one that you can do in the clinic, but you have to be aware, lower central incisor. Lower central incisor, there is study, it's been done, so many studies done. This one, the recent one, I have done. So there is about 28% of the cases of lower central incisors have two canals. So it looks like this. So whenever you have this kind of canal, the problem is if you have an access cavity from the lingual side and you put the file, you always got the buccal canal and you finish it up and you think you did a good job, but there is some missing canal. So if you have some experience or from today forward, hear my listen. Open the tooth. If you find the buccal canal in the lower central incisor, clean it, shape it to the master apical file, for example, 3004, 3006, whatever you like. Then after you clean it, you take the small round burr and dig a little bit in the lingual side, okay? So when you go in the lingual side, so you can remove this shoulder in the lingual, take a small hand file and do the pre-curve and try to go to the lingual side. If you have a catch, there is another canal, so you have to open more and more. For example, look at this case. If you have the access cavity from the other side, from the buccal or the tooth, let's say the tooth is broken already. So having access to the lingual side is very easy. So this is called the trajectory. Remember we talk about trajectory. It depends where you catch the canal. If you come from the lingual, the buccal is very easy. If you come from the buccal side, for example, this tooth is broken, so the lingual is very easy. So be aware that central incisor, whenever you find the canal, if you have a regular access from the lingual, almost 100% you got the buccal canal. So have a time and try to negotiate the lingual canal. If you have a loop, it will help a lot. If you don't have, then this is another problem. So here the access. If you have a tooth, you have two canals and you are sure, either you had a CBCT before or you are like, you notice it there and you make the orifice more in the center. Like for example here, if you have the access more in the center, the easy to find the two canals, or easy to see the two canals. So here what he did, he opened in the center and he can, because he used the microscope, he put two files, two paper point, two gutta percha, and he filled the tooth and it comes like this. So here the benefit of having magnification. And if you have already knowledge about anatomy, if you have a CBCT, so this is very important. So from now forward, you know that even if you don't have a CBCT, whenever you're treating lower anterior teeth, there is about 28-30%, there is another canal. So pay attention, okay? So my protocol in this kind of case, always locate the canal, clean and shape. So whatever canal you find, if there is a split canal, or if there is for example, MB1, MB2, whatever canal you find, clean it and shape it to the master apical file. Then start looking for the other canals, okay? Straight line axis is very important and must. Try smaller file always, 6, 10, 8. It's very important to the working length or to the available working length. What do I mean by available working length? Sometimes you cannot go all the way down. But if you go only halfway, that's perfect. After that halfway, take the orifice opener, make it wider. Irrigation, then the small file, the 6 or the 8 or the 10, it will go further in the canal. Coronal flare, improve straight line axis, as I said before. Glide path file, it's very important. If you have hand files, use the smaller one. If you have the rotary, that's the best. It will save your time. Follow with bigger but auto taper, heat treated files, the same that I show you, the small taper, the small file that very flexible. It will help to go all around. It's not going to be break easily. Then finish the case with O4 taper. That's what I mean by smaller taper. Don't go for bigger taper because the canal is already small. So using heat treated file is very, very beneficial. Okay. So other variables taper can work. You know, if you are expert in dentist or if you have expert GP, and you know there is so many system in the market, you can buy whatever fits your cases. Okay, there is no right and wrong, but this is only my recommendation from my experience, and also to be safe. So far we cover like a variety of cases that you might see in your daily practice. But if we go until there and we clean and find the canal, you clean and shape, and you're happy, do you think you are done? Absolutely not. This study has been done, and they found out if you clean and shape and you're happy, is about 30% of the root canal system is only touch. About 30 to 40% of the canal is not non-touch. So you clean, you do whatever you think you are doing, then there is a lot of root canal system anatomy inside is not touch. And that place you don't touch, what happened? The places you are touching, you're cutting dentin and debris or whatever, and you pack it on that side. So put this in your mind. So it's very important to have chemical irrigation. This is a root canal system, how it looks like after they inject some ink inside. So you see how the root canal system, there is so many places you will never ever reach it by the file. So we rely exclusively in irrigation. Irrigation, you can use whatever you like, chlorhexidine, EDTA, sodium, everyone has this benefit. But sodium hypochlorite is a must. Why? Sodium hypochlorite does two things. Disinfect the root canal system from microorganisms and dissolve the tissue. It's very important to dissolve the living tissue. Chlorhexidine, it will disinfect, but the tissue, pulpal tissue, necrotic tissue, it cannot be dissolved by chlorhexidine. So having a sodium hypochlorite is a must in root canal treatment. If you have extra solution, perfect, why not? We have to have some special needle for irrigation for safety. This needle that having a side opening, it's very safe. You can put it all the way down, irrigate, and you're safe not to push the sodium hypochlorite away out of the root canal system. Here, so many kind of like needles. There is some plastic that can go around the curve because the metal needle here is difficult to go around the curved canals. And also you have to have activation. What is the benefit of activation? So the solution will go inside the root canal system, the main one that you clean. But the lateral ones, the small ones on the sides, it cannot be reached. So you have to have some activation system to make the solution go on that spaces. So you can have this, call it sonic activation. You can have this one attached to your unit, or there is a special machine you can buy it, ultrasonic activation. Or eventually, if you don't have anything, have the master file and try to bump it inside the root canal system. So it's dynamic. So there is solution, there is an object. So get a Persia here, you put it up and down. The solution will go inside the places that you cannot touch mechanically. So the solution will go. Okay, it's a simple physics. So it will help to disinfect and dissolve the tissue that's present in there. Then later it will be filled by sealant. Eventually, after you finish your root canal treatment, please make sure that you put a good filling. So some people, they don't put good temporary filling. They just put a regular one and the patient will lose it in a week or two. So if the patient will not gonna go back quick to you, try to put glass ionomer. Otherwise, if you do the final restoration as soon as possible, that is the best. So eventually, the butter of this presentation and take-home message is it's all about you. If you want to learn something, if you want to see something that, if you want to see how you develop, how you learn, you have to be aware. You have to know your limitation. Go YouTube, go any channel. There is so many people presenting perfectly. Invest in yourself. Attend courses, workshop, attend clinical attachment. You have to have a mentor, somebody to have always to ask whenever you have difficult cases. Try other people, model other dentists. There is not only one solution for a problem. There's so many solutions. You have to try to find what's better for you. And eventually, you have to be patient. In our field, it's very difficult, it's very challenging, and you have to be patient so you can do always a good job by being patient. Even your patient will be happy to see you wise and patient, and you ask him to come for another visit so you can do a good job better than rushing everything at the same time and you don't do it perfect. So far I'm done. Thank you very much. Appreciate that. Who's doing this scratches in here? I'm done here. Thank you very much. Anybody having a question? So I'll be happy to answer.